26 gauge needle with the pulley suture is passed through the peripheral iris and externalized through the scleral tunnel. Suture is pulled out through the needle and held on. The needle is then gently withdrawn and the second line in the peripheral tissue is taken adjacent to the first one in the similar fashion and suture is pulled to form the loop. Once three loops are formed, the suture is gently withdrawn from the 26 gauge needle it is then passed through the loops. The ends are then tied and the knot buried in the scleral tunnel. Thus the pupil gets round and the arteriolysis gets repaired. This is followed by implantation of the lens and the conjunctiva is covered and cauterized. This is the post-op day 1. Thank you for watching the video. This video will demonstrate arteriolysis.
So, Dr. Amar wanted me to pause it. Okay, wait 1 minute. For some reason it doesn't pause there. Let's take it here. You want me to pause it here? Okay. We wanted to request Dr. Amar to comment on this and how we could, whether we could do it any way better or like he liked the video.
I think Manish, you've done a great job. And Manish is an excellent surgeon. One small thing, if you notice now, you have done either sewing machine or you do any iodiolysis hangback technique which you are doing. Now the point I'm making here is, look at that pupil. When you pull the iris like this, there will be a dilatation effect. So what you need to do is a two-fold technique. Now with this, once you have done this, fantastic. Now do a single pass 4th row pupiloplasty. And we published this in the JCRS. You understand my point? So if you do now a 4th row pupiloplasty, that dilatation effect which is there on this side will get neutralized. Yes. So this is what we call as the two-fold technique, where you're combining hangback and the single pass 4th row pupiloplasty. You can do it with sewing machine and single pass. But if you see in that picture, if you see on the top, wherever the iodiolysis is there, obviously you're pulling it on one side. So if you do that 4th row pupiloplasty, that pupil comes back to normal. Otherwise, I think it's a great thing. Small tip, you're playing this game with viscoelastic. Yes. Basically, yes. If you play this game with fluid using a trocar AC maintainer, every time you don't have to keep on injecting, and the fluid will automatically push off the blood, the hyphema which occurs or things like that, life will become very comfortable. Otherwise, it's a great surgery.
Another question, Dr. Amar, we noticed that almost all his steps, the needle was going inside out, do you think, because then coming out at the exact point where you've made that tunnel may not always happen when it's a blind technique. Do you think there was a way to kind of, I mean, in the hangback technique, probably not possible, but at least in the other
It's a very good point. I'll tell you, even in hangback, one of the problems, see, understand what he's doing in hangback, you're taking a double arm needle, passing it from the same corneal incision. Invariably, I tell you, many times what happens, you pass it in, you think you're in the incision, it goes through the cornea. Now when you're pulling, it's stuck to the cornea. Or a headache, again you have to cut and again. Simple trick. Take a trocar AC maintainer, pass it into the eye. But don't pass the fluid. Now pass the needle through the trocar. You understand, the trocar itself becomes an opening for you. That way you will never get that lock into the system there, and they'll make your life very easy. Okay? Right. What he's suggesting is another simple trick is, when you're bringing in the hangback, it doesn't come out through the scleral groove. So if you take another needle from the scleral groove, this side, and lock the two, railroad the two, technique. Then you'll come out exactly in the scleral groove exact area.
Yeah, that's a good point, sir, yes.
So thanks, Dr. Manish, and we'll now go on to the next one, Ashwin, and we have this, I'm just pushing it on, So we have Dr. Neeraj Agarwal, who will be speaking on iris fixation of subluxated eye-back complex. And Ashwin.
Posterior chamber intraocular lens subluxation or dislocation is uncommon but represents one of the most serious complications which needs surgical intervention. This video demonstrates two case scenarios of iris fixation of subluxated IOL back complex due to different etiology, which were managed effectively to restore the pseudophakic vision. The first patient was a 71 years old gentleman who had a history of successful phacoemulsification and intraocular lens implantation a decade ago, presented with mobile IOL bag complex in sulcus. A superior 6 mm sclerocorneal tunnel was created. Paracentesis was made at 3 o'clock position. The wound was entered with 2.8 mm keratome and was extended. Anterior chamber was filled with viscoelastic. The subluxated IOL back complex was extracted with the help of lens holding forceps and spatula, taking care not to disturb the anterior hyaloid face. The spatula was swiped to check for any prolapse of vitreous. Pilocarpine was injected and the pupil was constricted with the help of gentle strokes on the iris. A tenoproline suture in a long curved needle was passed through the cornea and full thickness iris and was brought out again through the cornea, ensuring that the iris bite is around 1.5 to 2 mm long. The same suture needle was rotated and used to take the corresponding bite 180 degrees away. A second paracentesis was made at 9 o'clock. A Kuglin hook was used to retract the proline suture below the iris, which was externalized through the main tunnel using McPherson forceps. The other suture was brought out in a similar fashion and kept on the corresponding sides. The right suture was looped thrice around the leading haptic of the IOL. The leading haptic of the IOL was slipped behind the iris. The external suture was gently pulled such that the suture around the haptic got taut and does not slip from the haptic. The other suture was looped similarly around the trailing haptic and rest of the IOL dialed into the sulcus. Both the suture ends were lifted to check for IOL tilt, thus ensuring that the suture is below the haptic. The suture between the cornea and iris was retracted out to the corresponding paracentesis using Kuglin hook and McPherson forceps. Both suture ends were tied together such that the knot lies over the iris. Around 5 to 6 knots were placed to secure the haptic firmly to the posterior iris. The other suture end was similarly secured. The viscoelastic was gently aspirated and conjunctiva was opposed with cautery. This was a 65-year-old gentleman with traumatic subluxation of IOL back complex in anterior chamber with vitreous prolapse. A paracentesis was made. Viscoelastic was injected in the anterior chamber. The leading haptic of the IOL back complex was slipped behind the iris, and a tenoproline suture in a long curved needle was passed through the full thickness cornea and iris, ensuring that the needle is passed behind the haptic and was brought out through the cornea. The trailing haptic of the IOL back complex was similarly slipped behind the iris, and similar bite was taken, ensuring that the needle was passed behind the haptic. Anterior vitrectomy was done to take care of vitreous prolapse. Both the sutures between the cornea and iris were brought out through the corresponding paracentesis, and both suture ends were tied together. The remaining viscoelastic was aspirated and the anterior chamber was formed with saline. With patience and perseverance, such challenging surgical situations can be overcome successfully.
Thank you, Neeraj, for this video. Dr. Boris, would you plan to do the same thing, or would you do something different? What's your comment on this video?
So talking about the first case, frankly speaking, in this case, I will probably not be removing that lens. I will try to suture it through the bag and through the haptic, and I do believe it works well. Of course, there was no CTR. However, I still believe that the haptic configuration will allow you to securely fixate it to the sclera. As for the technique itself, I think it was quite elegant, because for iris suturing of three-piece lenses, we're always struggling with pupil distortion postoperatively. So this is a nice way to avoid that kind of problem. And I really looking forward to try your technique, and maybe I would love it, as it seems simple and quite easy to do. So it's congratulations with that.
To
Sir,
Jagathan, any?
just one question. You told the first case you will fix the same back complex.
Yep.
But the lens was the single piece lens. Would it is advisable to fix
It's not.
that?
It's not a problem, because the lens is sequestered inside the bag. So there will be no contact in between the lens and the posterior surface of the iris. It will be no rubbing because of that. So it will be a contact in between the capsule and the posterior iris, and the sharp edges will be not in contact with the iris. So that's not a problem.
Okay, thank
I
you.
think two small comment. One is regarding vitreous. We have to ensure that it should be free from vitreous. I think triamcinolone may be used.
Yeah.
Another is that short-term results are excellent, but what is the long-term result of
Sir,
the
I have
technique?
followed this patient, I think, last 6 years. The patient is doing fine, and patient doesn't have any glaucoma till now. This is what one thing, and the suture, his lens is quite stable and well centered.
Thank you, Neeraj.